In Chapter 9, we're going to review signs, symptoms, and ill-defined conditions. A sign is defined as an objective or measurable evidence of a disease that can be observed by the examining physician. A symptom is a subjective observation reported by the patient but not necessarily confirmed objectively by the physician. Codes for signs and symptoms and ill-defined conditions from Chapter 16 of the ICD9 CM cannot be used as a principal diagnosis or reasons for outpatient encounters when the related diagnoses have been established. Diagnoses described as possible, probable, and so on at the time of discharge are treated differently depending on whether the patient is an inpatient and the diagnosis has been confirmed as established, or whether the patient is an outpatient and the diagnosis is not considered to be an established condition. If there is not an established diagnosis, only the signs and symptoms that are available at the highest level of certainty are assigned. Signs and symptoms are classified in two ways in ICD-9 CM. Those that are indicative of a condition that ordinarily affects only one body system, these are classified to the relevant chapter, or they're classified in Chapter 16 as those that can point to more than one disease or system or have an unexplained etiology. The first guideline does not apply if the diagnosis is stated as a symptom due to two conditions rather than as two contrasting diagnoses. In this case, both conditions would be coded, and the symptom code would be assigned as an additional code only if it met the criteria of reporting additional diagnoses. Generally speaking, symptoms classified to other chapters are not designated as principal diagnoses when a related condition has been identified. The symptom can be designated as the principal diagnosis, however, when the patient is admitted for the sole purpose of treating the symptom and when there is no treatment or further evaluation of the underlying condition. Outpatient encounters ordinarily do not permit the type of study that result in an established diagnosis, and treatment is often directed at relieving the symptoms rather than treating the underlying condition. The highest level of certainty is reported as the reason for encounter for outpatients. This often means that a symptom code is assigned as the reason for encounter. Signs and symptoms as additional diagnoses are done only when the sign and symptom is not integral to the underlying condition, or unless otherwise instructed by the classification system, or when its presence makes a difference in the severity of the patient's condition and or the care given. Codes from Chapter 16 are not assigned when they're implicit in the diagnosis or when the symptom is included in the condition code. Let's talk about abnormal findings, which are coded to category 790 to 796. These are assigned only when the physician has been unable to arrive at a definitive related diagnosis and list the abnormal finding as a diagnosis in itself, and when the condition meets the UHDDS criteria for reporting of other diagnoses. It is very rare to assign one of these codes during an inpatient acute care stay. The final section of Chapter 16 contains codes for ill-defined conditions or unknown causes of morbidity and mortality, such as senility without psychoses, asphyxia, nervousness, and sudden unexplained death. These codes should never be used when a more definitive diagnosis is available.